a horse. Today we're going to talk about tachycardias in ECG. We illustrate here a four-step approach to diagnosis of any tachycardia. First, we have to assess the QRS complex width. Is it narrow or is it wide? Then we look at the degree, is it regular or irregular? Then step 3, we look at the B wave, is it present or not? Then we assess the B to QRS complex ratio, right? So if we have a narrow complex tachycardia,
السلايدز واقفة يعني
we ask ourselves, is
دكتور رصاصي السلايد
أيوه
واقفة. السلايد
the
واقفة.
slide.
حرك كده.
انا بحرك
حرك السلايد.
البوينت.
ما هو بتتحرك
باين.
البوينتر. خلاص.
انت شايف انا سامعك، انت شايف؟
انا كده تمام.
طيب we look at the tachycardia. If it's a narrow complex tachycardia, is it regular or irregular? If it's regular, we assess is there a B wave or not. If we can't see the B wave clearly, it's mostly SVT or junctional tachycardia. If we have a B wave, we assess the B to QRS complex ratio. If it's 1-1, it's sinus tachycardia or atrial tachycardia. If there is B wave more than QRS, it's atrial flutter or atrial tachycardia with fixed block. If the neurocomplex tachycardia is irregular and there is no B wave, it's atrial fibrillation mostly. But if the B wave can be seen and the B to QRS complex is 1-1, it may be multifocal atrial tachycardia or respiratory sinus arrhythmia. And if the B to QRS complex is over 1-1, it's atrial flutter with variable log. So everything seems confusing. So let's break the ice and start with each type in detail for better understanding. SVT includes two types of tachycardia, AVNRT and AVRT. AVNRT has this mechanism which depends on the presence of dual immunophysiology. When we have two busways for conduction, one that conducts slowly but has a short refractory period, and one that conducts very fast but it has a long. So during sinus rhythm, as we can see here, the impulse goes here and conducts along the slow busway and the fast busway, and it reaches the ventricle across the fast busway because it conducts faster and blocks the conduction across the slow busway here. So we have this normal BR interval. However, when a premature beat comes, the refractory period of the is long. So the impulse blocks the fast busway and it conducts during the sinus rhythm. The impulse conducts across the fast busway, and we have this normal BR interval. The fast busway has a long refractory period and can conduct fast. And so the conduction across the slow busway is blocked. When we have a premature atrial beat, it comes through the slow busway as it's recovered, as it has a short refractory period, and it blocks in the fast busway. So we have this B wave with prolonged BR interval. When tachycardia happens, there is retrograde conduction also across the fast busway. So we can see here a retrograde P wave, and the duration from the beginning of the R wave to the P wave is very short. It's usually less than 90 milliseconds. You're catching up with me, right?
Yes, Rossasy, yes.
So we have this retrograde B wave, which is very close to the QRS complex. So it's called even a pseudo S or pseudo R, as we will see in the ECG examples coming right now. Then the tachycardia goes up and runs across the slow busway slowly to depolarize the ventricle. Then it runs again to across the fast busway to the atrium, and here the tachycardia goes on. Here is an ECG of typical AVNRT, and we can actually appreciate here there is a narrow complex tachycardia which is regular, and when we look at close, we can see that the retrograde B wave in the inferior leads forming like a pseudo S wave here in lead 2 and lead 3 and AVF. And there is a pseudo R wave in V1. So a rare type of AVNRT is called a typical AVNRT when the conduction from the ventricle to the atrium utilizes the slow busway, and the conduction from the atrium to the ventricle utilizes the fast busway. And we can see here that the AVNRT may have this strange form in which the duration from the QRS complex to the B wave is long, and from the B wave to the QRS complex is short, causing a longer RB tachycardia. Can we have some clues in the resting ECG? Actually, the resting ECG is usually normal. However, when we look, we may there is a prolonged PR interval in some patient, and this is not necessarily a first degree block. It's actually a slow conduction. So when you have an FVT and you have this resting ECG, you have to bottom line this patient might have a slow busway conduction. And Holter actually may be useful in such cases, as you can actually see the mechanism of tachycardia. Here is typical induction of AVNRT in Holter, and you can see that there is conduction across the slow busway, then retrograde conduction, the fast busway, and short RB tachycardia after prolonged PR interval. And here is the tachycardia goes, and it terminates with B wave, which is going with SVT and against atrial tachycardia. So this is the first type of SVT. The second type is the one that utilizes accessory pathways, and it's called AVRT, and it depends on accessory pathway. Till now you're catching with me, right, Dr. Shrif?
Yes, Rossasy, right.
So we have two types of accessory busway. The one that manifests itself in the resting ECG, and we can see it because it has an antegrade conduction from the atrium to the ventricle. So we can see it in the ECG, and the one that have a retrograde conduction and conduction from the ventricle to the atrium. And there is the one that's called concealed, which conducts only retrograde. So we can't see it in the resting ECG, but it may induce tachycardia. The manifest accessory busway causes what we call it a WBW pattern, or if it induces tachycardia, we call it Wolff-Parkinson-White syndrome, and it causes what we call it delta wave. Delta wave is the slurring in the initial QRS complex due to activation of the ventricle across the myocardium. As when we look at here, the conduction from the atrium to the ventricle across the pathway happens, leads to electrical depolarization in the myocardial tissue. So it's usually cause widening of QRS complex and the slurring in the initial part. And when the impulse goes across, there is the component of the QRS. And it's usually having a repolarizing abnormality. So the degree of pre-excitation, the resting ECG, depends on multiple factors. First, the speed of conduction of the AV node versus the accessory busway. If the AV node is fast, like in children, the accessory busway may be subtle, and we can't really see it very clear in the ECG. And the localization of the accessory busway, if it's away from the AV node of the SE node, like in left side accessory busway, it's usually more subtle than the right side accessory busway and the refractory period of the accessory busway. And we have multiple algorithms for localization of the accessory busways, like the one developed by Ain Shams University, which look at the R wave transition. If transition occurs in V1, it's left side accessory busway. If it's in V4 or more, it's more like to be right side accessory busway. If it's in V2 or V3, it's a septal accessory busway. Then you look at the inferior leads. If it's positive, it's an anterior accessory busway. If it's negative, it's a posterior accessory busway. The final step is that we look at the lateral leads. If they are negative, and we are talking about left side accessory busway, it's a left lateral accessory busway. So here is a resting ECG of some patient with tachycardia. When we look here, we can appreciate there is slurring of the initial part of the QRS complex there is widening of the QRS complex, and actually the RS transition occurs in V1. So this is with left side accessory busway. When we look at the inferior leads, it's positive. However, 1 and AVL are negative, so this is consistent with a left lateral manifest pre-excitation. Another example is this one. We have RS transition in V2, and when we look at the inferior leads, actually we can see that lead 3 and AVF are negative, so this is actually a post-receptal accessory busway. So what are the types of tachycardia that may be induced by accessory busway? They mainly induce two types: orthodromic atrioventricular reciprocating tachycardia and antidromic tachycardia. The orthodromic also means correct or the natural way. In this type of tachycardia, the impulse goes across the AV node, depolarizes the ventricle across the specialized conduction system, then goes across retrograde across the accessory busway. So you have this narrow complex tachycardia, and the retrograde P wave is actually can be appreciated here and here. It's close to the it's, if we classify it's a shorter RB tachycardia, but the B wave is somehow away from the QRS complex. This okay, you're with me, right? You're catching up with me, Dr. Sharif?
أيوة رصاص, yes, you are here.
تمام. So this is all from AVRT. And in Holter, actually appreciate the induction and definition of the tachycardia, and actually you can the change in the morphology of the QRS complex. In the resting here, we can see the delta wave, and then there is loss of pre-excitation and tachycardia, and the retrograde B wave is somehow away from the QRS complex and of the tachycardia with more manifest pre-excitation. So the next type of tachycardia that may be induced by the accessory busway is the antidromic one. Antidromic means walking in the reverse direction. So we have this antidromic tachycardia in which the impulse travels across the accessory busway. So the ventricular activation is actually slower, and it's abroad and bizarre. Then the retrograde activation of the atrium occurs across the AV node, and we have this white complex tachycardia. And actually, you can't differentiate it easily from VT. So when you are having a white complex regular tachycardia, your first diagnosis would be VT, but keep in mind that if you perform a cardioversion for the patient and it returns on a manifest pre-excitation and the echo is normal, you have to consider this tachycardia was an antidromic one. And the last type of tachycardia that may be caused by accessory busway or may be seen in patients with accessory busway is the pre-excited atrial fibrillation. Accessory busway can conduct actually at rates much more higher than the AV node. So when patient with manifest pre-excitation develops atrial fibrillation, you can see this rhythm, which is a broad and wide and bizarre and irregular rhythm, and it's called pre-excited atrial fibrillation, and it shows maximal degree of pre-excitation and different degree of widening of the QRS complex. And actually, you can localize the accessory busway. So if this one is pre-excited atrial fibrillation across a left lateral accessory busway. This one is mostly across a right side one. And this is also a pre-excited atrial fibrillation. Look at how the ventricle is activated very fast and how the QRS complex is broad and bizarre and irregular. Then we go to special types of accessory busway. The first one is the PGRT, or permanent junctional reciprocating tachycardia. This type of accessory busway is a concealed accessory busway, so it conducts only retrograde, it has only a retrograde conduction. But it has a decremental probers and it conducts slowly. So when orthodromic AVRT goes, the impulse travels across the AV node, so you have this narrow complex tachycardia, but the conduction from the ventricle to the atrium is very slow and decremental. So you have this long distance from the R to the P wave. So BGRT is a cause of long RP tachycardia. And the other special type of accessory busway is the Mahaim tachycardia. The Mahaim is a special accessory busway that connects the atrium to the ventricle, but it's very long and it usually inserts in the distal right bundle. So when you have a tachycardia mediated across this pathway, the impulse first goes from the atrium, then to the right bundle, then to the atrium. So you have a left bundle branch block tachycardia. And when you look at the resting ECG, you usually don't see any manifest pre-excitation because the accessory busway is long and decremental. So the AV node, most of the is activated across the AV node. So when you have a patient with a typical left bundle tachycardia and normal resting ECG, you have to put in mind the Mahaim tachycardia. It's because it's usually underdiagnosed. So we are done with supraventricular tachycardia, and we're going now to atrial tachycardia. Atrial tachycardia refers to when there is a focus activating the atria. So like sinus rhythm, you can see a P wave and short PR interval and QRS complex. But the P wave is not sinus P wave. It's actually having a different morphology. So atrial tachycardia in this ECG is typical of atrial tachycardia. And from the morphology of the P wave, you can appreciate if it's where it's coming from actually by different localization algorithm out of the scope of this lecture. By mainly we look at V1 if it's negative or positive. If it's positive, it's usually a left side atrial tachycardia. If it's negative, it's usually a right side atrial tachycardia. If it's positive negative, it's usually coming from the crista terminalis. Another form of tachycardia occurring in patients with chronic chest disease and chronic hypoxemia is the multifocal atrial tachycardia. When there is multiple foci, each foci activates the ventricle for one beat. So when we look at the rhythm strip, you can see that there is a P wave morphology and another morphology, and this is another morphology, and this is another morphology. And actually, the rhythm is irregular. So when you can't count 3 P waves of same morphologies, and there is a varying P wave morphology and PR interval, and the rhythm is irregular, it's usually a multifocal atrial tachycardia. And this one, treatment is mainly correction of the chest condition and rate control. So another differential diagnosis of narrow complex tachycardia is long RB tachycardia or short RB tachycardia. Short RB tachycardia are mainly typical AVNRT or orthodromic AVRT. Atrial tachycardia is long PR interval. Long RB tachycardias are mainly atrial tachycardia, typical AVNRT, BGRT, and of course sinus tachycardia. With me till now, right? Okay, Dr. Sharif?
Yes, everything is okay, Rossasy.
Okay. So another type is atrial flutter. Atrial flutter is a form of a macro re-entry within the atrium. The most common type of atrial flutter is the typical atrial flutter, which depends on the area of slow conduction at the cavotricuspid isthmus. And we can see here the atrial flutter has a special morphology of the ECG. It's called the sawtooth appearance. Refers to that the fact that atrium is in a state of constant activation during the whole tachycardia cycle length. So in typical atrial flutter, if it's conducting in an anti-clockwise manner like that, you can see in the inferior leads it's negative, and in V1 it's positive. If it's activated in the reverse direction in a clockwise manner, you can see that the inferior leads is positive and the V1 is negative. Also, there's a form of atypical atrial flutter which causes re-entry around different parts of the atrium, like re-entry around the scar or re-entry around the pulmonary veins or re-entry around the mitral valve, and they usually have a different morphology in the ECG. So we look at this ECG, we can appreciate the sawtooth appearance here, and is there anything wrong, Dr. Sharif?
لا كله تمام يا رصاصي.
ماشي.
Everything is alright. Yes.
So when we look at this ECG, you can appreciate that there is multiple P waves for each QRS complex, and the P waves are actually of the same morphology, and they are connecting to each other, like so, giving the sawtooth appearance, which refers to the state of continuous atrial activation during the whole the whole tachycardia cycle length in the atrium. So when we look at the inferior leads, it's negative in lead 2 and lead 3 and AVF, and in V1 it's positive. So this is the typical ECG of typical counterclockwise atrial flutter. In this one, we can see that there is multiple P waves for each QRS complex. But if we look closely, we can see that the P wave is positive in the inferior leads. In lead 2, it's positive. In AVF, it's positive. And in V1, it's positive. So this doesn't go with typical atrial flutter at all. Rather, it's a typical atrial flutter, and actually it's coming from the left side. A very serious tachycardia that may occur with atrial flutter is atrial flutter with 1-1 conduction. And here we can see that there is the sawtooth appearance here. Look at V1 here. There is P waves, and the P wave occurring actually at a very rapid cycle length. And you have one QRS complex for each P wave, and the ventricular rate is about 300. This is pretty fast, right? This is a medical emergency. It should be treated with defibrillation with the synchronized cardioversion immediately. So this form of ECG should be always kept in mind, especially in patients with atrial flutter. Finally, atrial fibrillation. There is chaotic atrial activity, and there is chaotic atrial activation from the pulmonary veins, and the AV node conducts intermittently by the AV node, as the atrial rate is 300 to 600. So actually the atrium is not contracting, it's fibrillating. And the AV node can only conduct few of these beats. So it conducts in an irregular pattern to protect the ventricle from this atrial fibrillation. And we can see here the ECG is usually irregular, and you can't actually appreciate a constant morphology of P wave. Actually, there is just fibrillation in the baseline. It's called the fibrillatory waves. So this is ECG typical of atrial fibrillation, and this one also is typical of atrial fibrillation. Here you can see that the baseline is undulating, and there is no clear P wave morphology, and the RR interval is irregular. So we're done with the narrow complex tachycardias. Let's go with wide complex tachycardia. As a rule of thumb, any patient with a wide complex regular tachycardia should be treated as VT until proven otherwise. So the safest option is that any patient coming to you with wide complex tachycardia, always think of VT and treat like VT, because this is the most serious one. But there are other causes that may cause regular wide complex tachycardia. like antidromic AVRT, which we illustrated in the previous section. And also SVT with bundle branch block aberrancy, pacemaker-mediated tachycardia and tricyclic antidepressant. The cause of irregular white complex tachycardia, the most common and the most important is the break-cited AF. Then comes the polymorphic ventricular tachycardia and AF with bundle branch block. Differentiate ventricular tachycardia, which is the more common and always should be kept in mind from SVT with apparent conduction. We have the Brugada criteria. The Brugada criteria involves 4 steps. First, concordance, which means that all the QRS complex in the pericardial leads are either R or QS. If there is positive concordance or negative concordance, it's VT. If there is no concordance, you go to step 2. Step 2, you measure from the beginning of the R wave to the nadir of the S wave in any of the pericardial leads. If the beginning of the nadir of the S is more than 100 milliseconds, this is consistent with VT and the tachycardia is VT. If it's not, you go to step 3. Step 3 looks for evidence of AV dissociation. When you are having atrial rate slower than the ventricular rate, and it can be seen actually pretty clear in this rhythm strip. And actually, it may be more evident if we can see fusion beats or capture beats. The capture beats is when a sinus beat comes and conducts in between the VT, and the fusion beat when there is a fusion between AV node conduction and the ventricular tachycardia. So the last step, if you can see any evidence of AV dissociation, you go for assessment of the morphology of the VT. If it's more like to be a right bundle morphology, you have 3 criteria that suggest VT in V1 and 2 criteria that suggest VT in V3. If you have a small monophasic R in V1 or taller left, the right one, and you have a QR in V1, this is consistent with VT. Also, if the V6 having QS pattern or just a small R and deep S, this indicates VT unless there is left, especially if there is left axis deviation. If you're having a tachycardia with left bundle branch block morphology, if you look at V1, if the time of the R wave is more than 30 milliseconds, or there is notching in the descending limb, which is called Josephson site, or from the beginning of the R to the nadir of the S is more than 20 milliseconds, this is consistent with VT. If not, you look at V6, if it's a QS or QR, this is consistent also with VT. Let's look at ECG examples. So here it's clear that we are having a white complex tachycardia. Look at the pericardial leads. You can see that they are negative. QS, 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 QS and V4, QS and V5, QS and V6. So this is a negative concordance. This is consistent with VT other than SVT. And when we look at this ECG, we can see that there is a change of the ECG morphology in between. So this is a run of VT, and actually it's having a bundle morphology, and the V6 is having a QS pattern, and V1 having this smooth monophasic R wave, and you can actually appreciate the AV dissociation here. Look at these ones, these ones, these ones, these ones. This actually AV dissociation. Another example of VT here, you can see the Josephson side, which is notching in the descending limb in V1, and this actually consistent with VT. But always keep in mind, there is a rule of thumb. Any white complex regular tachycardia should be treated as VT. Don't waste the time of the patient in the differentiation. This is actually for when you are evaluating the patient in the clinic, but in the emergency room, always remember that a patient with a white complex regular tachycardia should be treated as ventricular tachycardia. Special types of ventricular tachycardia, like this one, which we call it fascicular VT. Fascicular VT includes re-entry related to the conduction system. And the most common form of fascicular VT is the one that utilizes the left posterior fascicle. So actually, the impulse comes across the left posterior fascicle, and there is somehow re-entry in that in that area. So you have this ECG, which is having a right bundle branch block with left axis, and you can see actually if you apply the Brugada criteria, it's actually ventricular tachycardia because you're having this deep S in V6 and you're having left axis deviation in the limb. So this ECG is typical of fascicular tachycardia. Another form of VT is the Torsade de Bois, which is a form of polymorphic VT, and you can see that there is a change in the morphology of the QRS complex, and in some limbs they may look like as they are twisting around the point. This is the meaning of Torsade de Bois, which is twisting around a point. And this one actually happens with patient with acute ischemia or electrolyte abnormalities and long QT patients, etc. Another form of VT is the bidirectional VT, in which you're having two morphologies alternating with each other in each beat. So this one and this one is positive, this one is negative. So this is called bidirectional VT, and it's usually pathognomonic of a few pathologies like catecholaminergic polymorphic ventricular tachycardia and also the lanopsin toxicity. An important type of ventricular tachycardia is the bundle branch reentrant VT, which causes a typical left bundle branch block tachycardia. And it's usually not very wide because it utilizes the conduction system, but it happens almost exclusively in patient with conduction system disease or patient with dilated cardiomyopathy. There is re-entry utilizing the conduction system. The impulse goes here and goes across the right bundle, then it activates the ventricle and goes up in the left bundle. So it's utilizing the right bundle. And what you can see that is the conduction that is occurring across the right bundle. So you're having a typical left bundle branch block morphology. And this tachycardia is easily curable with ablation as you can easily ablate and target the right bundle, and you can cure this tachycardia. Also, this tachycardia is life-threatening and a malignant one, so it's not nice and shouldn't be confused with Mahaim tachycardia or with conduction. So this is also an ECG of pacemaker-mediated tachycardia. Actually, the mechanism of pacemaker-mediated tachycardia is out of the scope of this lecture, and it will be illustrated in depth in the devices course. But always remember that if you're having a patient with a pacemaker presenting with fast rate and all the QRS complex are based, and he has a dual chamber pacemaker, should put in mind the pacemaker-mediated tachycardia. A final cause of 5 complex tachycardia is actually the sodium channel blocker toxicity. And actually, this is a sinus tachycardia, but the sodium channel blocker toxicity causes widening of the QRS complex. So it causes a very wide QRS complex, and it may be confused with VT, but actually, this is a sodium channel blocker toxicity, and you can see there is a positive R in AVR and widening of QRS complex. So this is most of our lecture. We are just going to mention what's meant by premature beats. We have two types of premature beats. One, when you are having a premature beat in the atrium, that's called the premature atrial contraction. When you are having a premature beat in the ventricle, it's called the premature ventricular contraction. When you are having a premature atrial contraction, this is the atrium, this is the AV node, this is the ventricle. So you're having this nice sinus rhythm, and a beat comes before its time in the atrium, and it conducts actually across the AV node and causes a premature beat, which has an recurrence complex and resetting of the next beat. So it comes earlier than its time. So it's not coming in its time, it's coming earlier than its time. So premature atrial contractions are usually followed by an incomplete compensatory boost. However, when premature beat is coming from the ventricle, it comes early here, and it blocks the conduction of the next atrial beat from the SA node. So it's usually followed by a complete compensatory boost, which means that if you measure the BB interval from this beat to the first sinus beat, it would be twice as the BB interval in sinus rhythm. So this is an example of atrial premature complexes. You can see here, this is a sinus beat and followed by premature atrial beat, which conducts across the AV node. But this one, you are having a premature ventricular for its time, and actually the boost after it, it's usually longer than the one coming after the BSCs. When you are having more than one premature ventricular beat or atrial beats, if there are two, you can call it couplets. If there are three, you can call it triplets. Also, there is quadruplets and like that. The last thing you should always remember that when you are having this irregular rhythm, it's not atrial fibrillation or multifocal atrial tachycardia. Actually, this B wave is sinus B wave, and it's positive and same morphology in lead 2, and it's negative in AVR, so and biphasic in V1. So this wave is a sinus wave, but the irregularity is caused by the autonomic nervous system activation with respiration. It happens usually in patients with high vagal tone, and it's called respiratory sinus arrhythmia, and it usually requires no treatment and usually asymptomatic. So this is an ECG finding.